Dr. Ethiraj Balaji from Singapore. He has MSc from Madras University and PhD from the University of Madras in 1991. He is head and chief of embryologist in the institution of Thomson Infertility Center of Singapore. And he has more than 18 years experience in IVF lab and andrology and National Sperm Bank of Singapore. He had many papers that published in the journals, and he had workshops and teaching adjunct lecturer and trained more than 20 embryologists. His topic is about the impact of GnRH analog on embryo quality and embryo development. Please.
Thank you for the nice introduction, Chairperson. Good morning, how are you all? You all good? Great. Okay. So this is how I'm going to deliver my lecture. So I'll be talking to you about role of GnRH analogues in ovarian stimulation. And then we'll talk about a little about agonists and antagonists, and then the effect on embryos. So we know that when you want to do an ovarian stimulation, usually it is supposed to be better than outcomes of the natural cycles. But however, all of us know that it's still suboptimal because we are aiming for multifollicular development to have more embryos so that you can transfer few and then you can actually cryopreserve the excess supernumerary embryos. So when we aim for this, these multiple follicles are going to produce more estradiol. So there is a feedback to pituitary, and it results in premature LH surge. So now we need to avoid this premature LH surge and then subsequent luteinization and ovulation. So you need to desensitize pituitary, which is very mandatory to avoid this premature LH surge. So we go for GnRH analogues. So the agonists are modified decapeptide GnRH. I think they are in use for about nearly 30 years. And they actually occupy the GnRH receptors and result in rise of gonadotropins. And continuous occupation of these receptors by GnRH analogues is going to cause the desensitization. So gonadotropin level falls and pituitary and ovarian suppression achieved. So ovarian stimulation is initiated with exogenous gonadotropins subsequently. Whereas antagonists are competitive binders of GnRH receptors. So they are very immediately effective and do not result in flare of the gonadotropin level. And because of that, they may require less exogenous gonadotropin. But these are actually to achieve the ovarian suppression of pituitary desensitization. Then why are they going to affect the embryos? Right. GnRH receptors are found on oocytes, embryos, pre-implantation embryos, and also on placenta, right? So there is a concern about the effect of GnRH analogues on embryo quality and development. So, but how do they affect? GnRH receptors present on oocytes embryos, as I told you before. So there is a concern about these analogues and the effect on embryo quality. Usually the antagonists, they lead to decreased synthesis of IGF and EGF, the receptors and the factors, also mRNA. And because of this, IGF and EGF receptors, which are important for mitogenic cascade, the cell division of zygote may be retarded. So that gives us the worry. So let us see first what happened in the animal embryos. So rodents embryos have been affected. So there is an inhibitory effect on the development of mice embryos. And also blastocyst development has been delayed in mice. And reduced mean number of cells in superovulated hamsters. And lesser number of cells and microvilli on mouse blastocysts. So that will cause a problem in implantation. But when it comes to human embryos, generally, lesser oocytes are obtained from antagonist cycle, and thereby you get fewer embryos than agonist cycles. And also, the effects on development competence of embryos could be there. So again, like in animals, this might be because of the disturbance in mitosis of this embryo. So you may have a delayed development. So generally in antagonist cycles, the embryos are slower than agonist cycles. A study which looked at the early cleavage rate of embryos at 25 to 27 hour post-IVF ICSI on day 2. They saw that antagonists actually caused the delay in cleavage, the early cleavage, whereas agonist cycles, the early cleavage embryos are more, right? Again, this explains that antagonist has an influence on the mitosis of the embryo. But whereas when it comes to day 3, there was no difference in the development of embryos, whether they are from agonist cycle or antagonist cycle. Okay, so this one is explained like this. Antagonists have a longer half-life, so the effect is there until the first mitosis is occurring in the embryos. But whereas this effect of antagonist is going to subside after day 2, so by day 3, the embryos are actually becoming normal. So at the end of the day, when you look at the cleavage rate and pregnancy rate, implantation rate, there's no difference. Also, the higher rate of zygotes are found to be with normal pronuclear morphology in agonists than antagonists. And top quality embryos, multinucleated blastomeres, fragmentation level are same between both agonists and antagonists. Embryo quality was higher in antagonist cycles than agonists, but fertilization rate was higher in agonist cycles, leading to more number of embryos available. And antagonist cycles usually yielded more number of embryos than agonists. This is another study in poor responders particularly. However, all other parameters were similar in both groups. And many other studies also showed that there is no difference in embryo quality between agonists and antagonists. The pregnancy rate and implantation rates were also not different. And usually we know that good embryos come from good eggs. So embryo quality may be affected indirectly through oocyte quality. This could be one hypothesis. More oocytes with cytoplasmic dysmorphism are found in antagonist cycles. So when there are increased incident of cytoplasmic dysmorphism, this might affect the embryonic development later. And however, the Zono score is found to be better in agonist cycles. We know that Zono also leads to problems in implantation when it is thicker. And smooth endoplasmic reticulum clusters are lesser in those oocytes which come from agonist cycles. And whereas in antagonist cycles, these clusters, which look like vacuole on the eggs, are more. Usually these eggs will lead to poor fertilization rate and poor development. So the other way of looking at these embryos is that you see whether the chromosomal competence has been affected. But so far there is no direct evidence on the effect of GnRH analogues on chromosomal competence and epigenetics of the embryos. However, the rise in supraphysiological estradiol level due to GnRH may cause detrimental effect on embryo implantation, particularly when it comes to cell adhesion in mice. But however, you look at the endpoint, the pregnancy rate and implantation rates in human beings, there's no difference. And the studies done on frozen thawed embryos showed that the high-dose antagonists will not have any impact on the survival rate and in the pregnancy rate of frozen thawed embryos. So now, after going through this account and then also listening to Monica just before, now we see that the data is really confusing. So some say there is an effect, some say there is no effect, right? So, and the number of studies available for the effect of analogues on embryo quality is very, very less, very scanty. So now, then why are we talking about this? We worry about that maybe the effect on embryos, what we see in real life, may not be really by the agonist or antagonist, right? It can be linked to the ovarian stimulation programs, like you are using more and more gonadotropins, like what our previous speaker talked about. So exposure to supraphysiological level of gonadotropins may cause the adverse effect on embryo quality and development. Right? And as I said, studies on the effect of GnRH analogues on embryos are very scanty. But however, I thought that I can share this also with you. I found this paper interesting. You can use the GnRH as a trigger. So triggering maturation of oocytes usually is done with HCG, so you can do this with GnRH analogues also. Sometimes lower pregnancy rates has been reported compared to HCG triggered cycles. But there was a paper by Ethiraj and its group. So they administered the agonist 6 days after ICSI, and it resulted in higher implantation rate. So this is one paper which shows a higher implantation rate by using a agonist luteal support. But when it comes to agonist trigger and HCG trigger, in frozen embryo transfer cycle, there was no difference reported. Right, so to summarize, now we are at a very confused stage. It's very difficult to confirm the adverse effect of GnRH analogues on embryos with available reports. And high level of exogenous gonadotropins is causing adverse effects on embryos rather than GnRH themselves. So before I end my talk, I thought I can share this story with you. So this was done in Singapore, in KK Hospital. There was this cancer patient with ovarian cancer. So one of her ovaries was removed. So she went through chemotherapy, after which she got cancer on the other ovary. So she has to come back for oophorectomy. But anyway, she's very young, about 22 years old, planning to get married. So she underwent oophorectomy, but the oncologist spoke to me. So I said, okay, you cut the ovary and send to my lab. So they sent the ovary to me. So I punctured the visible follicles and then pick up those follicles, mature them in vitro with the Purigon and a pregnil for FSH and LH. So I collected 4 eggs, all 4 matured the next day. So by the time we did this, she got married. So we got the husband's sperm, did ICSI, all 4 fertilized. And 3 were usable embryos, so we froze these usable embryos. This happened in 2010. And 2011, she came back. She was all right. Her cancer was treated very well. So she came back for a frozen embryo replacement. So we thought 2 of these embryos, both survived, we transferred. She got pregnant and delivered a baby boy just recently. And when we went through the literature, we found that this is the world's first pregnancy and live birth from such ovarian cancer case, where the embryos are developed from surgically removed ovary. Right? So I thought I can share this with you. So with that, I thank all of you for your patient listening. Thank you. And good day.